present some of our own data and some data by other people. Can I get the slides on, please? Thank you. It's pretty obvious from what we just heard that it's very important to be physically active for a variety of different reasons. And as an overview picture here, just illustrating that some of the things we've already been presented in the first talk was the fact that the quality of skeletal muscle will have an influence on development of lifestyle-associated diseases, which will lead to both increased morbidity and mortality, and that can be to some extent counteracted by exercise. The other part of the coin, talking about disability, which you saw at the end of the last presentation, is the question of whether the fact that we have muscle make us able to function for a longer time. And I'm going to concentrate in my presentation only on the lower part, asking the question, to what extent is this muscle loss that will lead to an increased risk for fall and fractures and also lead to morbidity and mortality associated with inactivity, and to what extent is it something that is an inborn effect of aging, the sarcopenia, the loss of muscle. Just the loss of muscle doesn't mean so much, but the important outcome is the functional outcome. And this is just some very classical data back from '94, showing that if you estimate the function of elderly people using, in this case, a short physical performance battery test, where you can score from 0 to 4 points, depending on how good you are in getting up from a chair, how fast you can walk 4 meters, and how well you perform a variety of different balance tests. You can actually demonstrate that there is a correlation between the ability to do this and the risk for death in a big population of elderly people. So the better you perform functionally, the less risk for death you evidently have. Evidently, this is just correlation and there's no causality necessarily in this, but at least it gives us a hint. So let's take a close look into what's happening with muscles as we age. These are some cuts from the thigh muscle MRI scans where you see all the way from young people up to the age of 85. And what you can see is the fact that you have the bone here in the middle and the muscle around, that not only is there less muscle as you age, but there's also an indication that the subcutaneous fat tissue is increasing, and also within the muscle you can see that there is a change of the pattern, which primarily is fat tissue and also some connective tissue. So what happens when we lose muscle? Well, the first information is that the number of muscle fibers go down. It's been illustrated over a variety of years that after the age of 50, there is a dramatic drop in the number of cells in the muscle. In addition to this, you also get to a situation where you get smaller muscle fibers. This is young muscle and this is old muscle. And I think you'll appreciate that the muscles are much smaller here in the old muscle than they are in the young muscle. Actually, you can make this lifeline of a magnitude of a skeletal muscle fiber, and you can see here, it's depicted schematically here, that you rise in the cross-section area of a muscle fiber until you're adult, and then it goes backwards again. Interestingly, that when you are at the age of 90, you have the same size of a muscle fiber like an 8-year-old, just for comparison. So, taking these things together, what you find with aging is a drop in the muscle amount in the cross-section area. And this is accomplished due to the fact that you lose muscle fibers, but also due to the fact that you lose size of each of the muscle fibers. There is a difference in that you lose type 2 or the fast white fibers faster than you lose the type 1 fibers. And that means that not only do you get less muscle, but you also get more muscle dominated by slow fibers at the end, at the very old age. In addition to this, you also lose some motor units, some spinal motor neurons, and some nerve axons. So, not only is the muscle lost, which can be shown that after the age of 65, you lose approximately 1.5% per muscle per year, but due to the fact that you lose preferentially most tissue in the fast fibers, you also get slower. And you actually get more slow than you lose muscle. So you actually lose the ability to do fast contractions much more fast than you lose the amount of muscle mass, and that can be shown here if you test how quickly people can do a maximal contraction. This illustrates the maximal contraction, but the slope of this will illustrate how fast you can do it, and if you calculate the area under the curve, you evidently will get the power. So you get less muscle with aging and you get slower. And this is very important because high muscle power relates better than total muscle mass to a functional performance, and that is very important for what we do in everyday life. So it's not enough just to be very strong, you also need to be able to do it rather quickly in order to avoid, for instance, falls. So the question is, what factors are involved to explain the muscle loss? And one of them is, of course, the loss of muscle fibers and the amount of muscle tissue, especially the reduction in type 2 fiber size will lead to low muscle power, and that will, of course, lead to decreased muscle function. The question is, can we counteract it by being physically active? A 100-meter sprint is far more than just muscle mass, but at least it indicates some of it. And you can see here from data from European Championship that if you look at these elite athletes all through up to the best master athletes, you can see that despite the fact that these people are training very vigorously, and I think it's very well accomplished at the age of 85 to be able to run a 100-meter in 17 seconds, you can still see that it goes the wrong way. You get slower with aging. And these are very selected people, and despite the fact you cannot keep the curve like this. So it is going downhill, whatever we try to do. The question is, how much does it go downhill? This is a cross-section area in master athletes. Untrained elderly men at the age of around 70, endurance-trained master athletes who've been active all their lives, and strength-trained athletes who've been active all their life. I'm not going to concentrate on the oxidative capacity, but that can be maintained to some extent in the endurance-trained. But the interesting thing is that the strength-trained athletes at the age of 75, they had, of course, the highest strength and the highest rate of force development. That is how fast you can contract your muscles. They had higher quality of their muscles. They were better to contracting their muscles fast than if they were compared to 30-year-olds untrained. They were not better than 30-year-old trained, evidently not, but they were at least 40 years younger from the quality of the muscle. And I think that's quite interesting that you can avoid a lot of this drop. Okay, these are master athletes. If you take very untrained people, what will then happen if you start training? These are totally untrained people at the age of 90 who starts training. This is the muscle before they start training, and this is after 3 months of training. And you can see that there is a rise in each of the muscle fibers. This is a cross-section area of the muscle. Interestingly, I told you before that the fast twitch fibers were losing more tissue with inactivity, but very friendly enough, training will provide us with a faster increase of this. So these individuals get more muscle, and they also get faster. And this is very important. I think this lady who's 97, she doesn't care so much about her cross-section area of her type 2 fibers. What she cares about is how fast she is in rising from a chair and how fast she can walk. And I think it's interesting that just 12 weeks of training, and there's a variety of studies showing this, I've just given you one example here, shows that you will actually get 20 to 30% better in everyday activities by starting training, despite the fact that you've never performed training before. If you have been through an operation for osteoarthritis, for instance, as in this case, and you're around the age of 70, and you, after operation, either get a standard rehabilitation program, or get electrical stimulation, or start vigorous, intense exercise training, you can also get this effect. You can actually see that people who undergo strength training right after their operation, they will improve much more in strength of the thigh than people who just go through the standard rehabilitation who get some electrical stimulation. So the point I want to make is not only in healthy elderly, but also in people who've undergone surgery, you actually can improve the strength by strength training right after. And maybe more importantly for the function is that the improvements in the strength were correlated very nicely to the ability to walk fast, and by the way also to being admitted for a shorter period of time at the hospital. So there might be benefits on a lot of levels by doing physical activity in these groups. And final example here is an example in elderly women who certainly not are sports people. They've never performed sports before, but they're having comorbidities. Some of them have heart disease, some have lung disease, and they all have the thing in common that they were coming into this study because they were admitted to the emergency room because of a fall injury. So they're all at high risk for fractures further on. If you train these they will actually become stronger. They underwent a 6-month training program, and they got stronger, and they were also increasing their muscle power, which can be estimated in a device like this, where you kick with your legs at the highest possible speed. The control group did not improve over this period, and interestingly, these women who trained for 6 months maintained their improvements also for the next 6 months without doing any formal type of organized training. So you might ask, is this really important? Is it important to have a high power for elderly? Well, I would say yes. In this group of women who trained, you can see that the normal walking speed improved, like is indicated here, compared to the control group. And the maximal walking speed improved like this. And just for your information, if you phone the traffic control in Copenhagen, you will get the information that the traffic lights are set at a speed, or you can say, they assume that people are able to walk in this speed range. So in order to cross a street in Copenhagen, you'll be able to walk at this speed. And you can see this group of patients are right at the spot where they would have to maximally activate their walking speed just in order to be able to cross the road. So an improvement of 10-15% really makes a dramatic difference to these people. They're actually able to cross the street much more easily. And maybe this makes the difference between whether you dare to cross a street or you stay at home and don't do anything. So I think there is pretty good evidence from a variety of different studies that all the way from basic physiology measurements of muscle performance, increasing the knee strength, all the way up to functional ability and daily activity, that there is good effect in both healthy and diseased elderly people. And normally when we talk about very healthy people, we can take very vigorously healthy elderly people at 80 and do muscle training on them and make them stronger. But they already have a pretty good function. I think where we really should focus is the group here who are very, very much at risk for having fall injuries, for physical disability and balance abnormality. Here